Here is your question. Right. So if you have read and understood, considering a critical care scenario, kindly tell me, how would you manage this patient?
Yes, I will manage the patient according to the CRISP protocol
Yes.
through ABCD approach, considering patent airway, normal breathing. Maybe there is tachypnea as the patient with hypovolemic shock. The most important is circulation
Yes.
to secure two large wide bore IV line, especially
Yes.
in the orbital fossa. The
Yes.
patient, yes, the patient with grade 2 hypovolemic shock, as the heart rate is about 125 with decreased blood pressure and elevated temperature. So the patient, we must also take a venous sample for blood count, cross matching, and VBG and lactate, and search and start with the fluid challenge test in form of crystalloid, and if no response, considering colloid resuscitation for the patient. Also give the patient antibiotic at the patient with fever.
Yes.
Also considering give the patient is painkiller at the patient came with abdominal pain. After that, we will go to disability. The patient is conscious or not, evaluation and exposure for any other source of bleeding rather than the history of bloody diarrhea. Okay. Yes.
The labs of the patient shows that patient has hemoglobin 8.5. That means that patient has some type of anemia. Can you tell me what or which type?
Mostly microcytic hypochromic anemia.
Yes.
Yeah.
All right. Why do you think patient would have this type of anemia?
Yes, as the patient is with long history of
bleeding. Yes,
bleeding,
or blood in diarrhea. Yes.
of blood diarrhea. So usually a chronic blood loss
yes
is equal to microcytic hypochromic
Good.
anemia. Acute
So,
blood loss.
Yes. Complete your sentence, please.
Yes, acute blood loss is equal to normocytic normochromic anemia.
Good.
Yeah.
Can you suggest or can you explain why patient might have raised TLC?
Yes, due to increased inflammatory process, maybe due to the cause, according to the cause, inflammatory cause, as inflammatory bowel disease, as ulcerative colitis or Crohn's disease, or infective gastroenteritis, bacillary dysentery, amoebic dysentery, ischemic colitis, or colitis by Clostridium difficile or Campylobacter jejuni.
Can you please tell me what are the differential diagnoses that you will consider for this patient?
Yes. For this patient, ulcerative colitis and Crohn's disease,
yes,
ischemic bowel, infective gastroenteritis, colitis with Clostridium difficile, amoebic dysentery, bacillary dysentery.
All right. Where do you plan to manage this patient?
Yes, as regards this patient, I will manage patient according to ABCD approach, but I will order some investigation in form of the first one is full blood count, ESR, CRP, and also lactate, stool analysis, stool culture, and also
Yes.
carcinoembryonic antigen to exclude any colorectal cancer, and calprotectin in the stool to exclude ulcerative colitis or Crohn's disease. And the last one, after subside of the inflammatory process, the most important to do colonoscopy to define or to detect the source of blood diarrhea.
All right. Okay. Considering that patient has acute condition and acute inflammatory or infective condition, you can say, what are the risks, the most common risks that you, or the most common complication that you can expect to happen in this situation?
Yes, toxic megacolon or perforation.
Yes. Very good.
Yes. Yes. And
how do you suggest to manage that?
I will manage according to if the patient will start by manage the patient in form of ABCD also, give
Yes.
a proper antibiotic, IV fluid, nail
Yes.
mouse, decompression of the abdomen, give the patient proper antibiotic. Maybe if the patient is confirmed with ulcerative colitis, give the patient proper dose of steroid according to the guidelines of ulcerative colitis or inflammatory bowel disease. If the patient refractory to the medical treatment, I will consider the surgical treatment.
What
Yes.
would that be? What surgical option can you offer?
Yes, then proctocolectomy and ileostomy.
With ileostomy. Okay. Right. Can you please tell me, patient has high platelet counts and raised TLC as well. CRP is also high. Why you will not transfuse blood?
As regards this patient, the patient is in sepsis, and the
Yes.
patient is feverish,
Yes.
and also the hemoglobin not less than 7 gram to transfuse
Yes.
the patient.
Very
Yeah.
good. So this is
Yeah.
more than 7. Okay. Can you please tell me, patient has low sodium and low potassium. How would you take care of that?
Yes, the cause of this due to a loss of diarrhea.
Yes.
I will give the patient a replacement or crystalloid in form of
Yes.
normal saline, including potassium chloride, to replace both sodium and potassium. The cause of this due to decrease or hypovolemia, stimulate renin angiotensin system, stimulate aldosterone, leading to salt water retention at the expense of the potassium. But after that, sodium will be lost also in the diarrhea or by the kidney to neutralize chloride also loss.
Good. Can you please tell me in which conditions patient can have or patient can present with high platelet counts?
As the patient is in acute platelet is acute phase reactant, so increase with acute inflammatory process. The patient may be due to is in dehydration state,
Yes.
so increase also the platelet.
Or in case of acute bleeding going on. Okay,
Yes.
if you are asked to do an imaging for this patient, which one would you choose and why?
The first and the primary evaluation will be plain X-ray abdomen.
Yes.
Okay.
To rule out
to
what, or
detect-
to
Yes,
what?
to rule out the first one, any perforation in form of air under the diaphragm. The second one, presence of source of obstruction, malignant or complicated structure after Crohn's disease or ulcerative colitis.
Yes.
In form of air fluid level.
Yes.
And the presence of
help me
and
to
the
read
toxic
this?
megacolon also.
Yes.
Yes.
Can you help me to read this X-ray?
Plain X-ray, yes, plain X-ray abdomen showing a dilatation of the ascending and transverse colon with narrowing mostly in the descending with characteristic what we call thumbprinting sign due to edema. Yes, thumbprinting sign due to edema of the wall.
Sign?
Yes, due to inflammation of the colon leading to edema of the wall with indentation of the haustration into the aerated lumen of the colon, leading to the characteristic thumbing printing sign.
Very good. Okay. Can you please tell me, how would you decide which antibiotic to be given to this patient, as the patient has raised CRP and raised TLC and patient has fever? So you know that patient has underlying infection or sepsis, as you said.
Follow up the patient according to the antibiotic. If the patient decrease the number of frequency of diarrhea and decrease the fever and decrease the CRP and TLC, and according to the antibiotic choice will depend on the stool culture and the proper involvement in the local policy of the hospital and the microbiology team.
Good. Good. Right. Thank you.
Thank you.
Good, that was good prepared. Good, and here is your patient. Right, so if you have read and understood considering the critical care scenario, kindly tell me how would you manage this patient?
Ma'am, I will manage this patient according to CRISP protocol by
Yes.
ABCD approach. Ma'am, I will, as patient is 80-year-old male, I will check for the airways. If patient
Yes.
is able to breathe, able to speak properly, then the airways will be secured, ma'am. And then I will go check for the breathing. I will note the breathing. I will check for any pleural effusion, or I will just auscultate the chest for the same. And then I will check for the circulation. I will check for the peripheral capillary refill time, and I will insert a 2 wide bore cannula, and I take the samples and sample for that, ma'am.
Anything else in particular that you will do?
Ma'am, I will start the because the patient is having high potassium, ma'am. I will check for ECG monitoring. I will check for ECG monitoring, and I have to start after taking proper history, I have to start the correction for ma'am potassium.
First you'll stop all the potassium containing intravenous fluids that patient is taking or being given to the patient. After
Yes.
stopping them, then you can arrange and you can manage to resuscitate.
Yes.
This is very important. Okay, how would you take care of cardioprotection?
Ma'am, for
Potassium
cardiac,
is 8 yes. Please.
ma'am, for cardiac protection, I have to start the patient on calcium gluconate, ma'am. 10
How
per
much
10
would you give and how?
10 ml of 10%, 10 ml of 10% of calcium gluconate will be given IV over 10 minutes, which
Very
provide a
good.
cardiac protection.
Anything else that you can give to correct
Ma'am, I
the
will
high
give,
potassium level?
ma'am, I will give 5 to 10 unit of insulin in
Very good.
50% of dextrose
Over?
over
Over
30
how
minutes.
long? Over 30
Over
minutes. Okay,
30
good.
minutes, ma'am.
Is there any other option that you can
Ma'am,
have?
I can give you, I can give the patient potassium resonim,
Yes.
15 ml per oral and 30 ml per rectum, ma'am.
And if that
And
fails, then
we can guide, ma'am. If it fails, we can go for hemodialysis, ma'am.
very good. Okay.
And if we can give salbutamol also, ma'am, 5 to 10 gram per minute, ma'am, by
Yes.
intravenous.
Okay. Can you please tell me what is the normal situation? What is the function of potassium
Ma'am,
ions in the body?
potassium helps in the nerve conduction, ma'am. Potassium helps in the cardiac action potential. Potassium helps in the, ma'am, skeletal muscle functioning, ma'am.
More. Please tell me more. Okay. Regulation of water electrolytes in cells, etc. Okay. What can happen if potassium levels cannot be remained normal and they increase?
Ma'am, potassium can lead to lethargy, ma'am. Potassium can lead to confusion. Potassium can lead to muscle weakness and cramps. It can lead to paralytic ileus. It can lead to atrial fibrillation or ventricular tachycardias, ma'am. Arrhythmias.
Okay. If you are asked to do the ECG in this patient, how would you expect a typical ECG in this patient to be?
I will see a wide QRS complex as well as peak T waves, ma'am. Tall T waves.
Anything else?
And arrhythmias, ma'am. Patient can have
PR
a
interval as well.
prolonged PR interval, ma'am.
Yes. Okay. Can you please tell me what is the diagnosis in your opinion in this case? What has happened? Why patient is dementic and yes.
Ma'am, it can be due to
Okay.
prerenal acute renal failure, ma'am, due to patient decreased water intake due to dehydration as patient is dementia, or it can be due to obstructive uropathy, ma'am.
Yes. Okay, good. Then what are the sequelae which causes uremia in patient?
Ma'am, because of the acute kidney injury, ma'am,
Yes.
there is decreased functioning of the kidney, ma'am. Renal function decreased functioning of the
Yes, that leads to deficiency of what?
erythropoietin, ma'am.
Very good. And then tell me the sequelae. Yes, please.
Ma'am, it leads to the deficiency of erythropoietin, which leads to, ma'am, which leads to decrease in hemoglobin formation, ma'am, and
Yes.
and subsequently, because it has decreased, it lead to, ma'am, potassium. It lead to excretion of the calcium, which lead to hyperparathyroidism, and it lead to fibrosis and lead to osteitis, fibrosica cystica, ma'am,
Yes.
in the bone marrow, which lead to increased white red blood cell
Increased
spread.
fragility in dialysis. Yes.
Yeah.
All right. Good. Okay. Can you please name few indications for dialysis in the patients with high creatine and high concentration? Yes.
Refractory hyperkalemia, ma'am. Refractory hyperkalemia and uremia, ma'am.
Uremia, encephalopathy, fluid overload, hyperkalemia, acidosis. There are many
Yes, ma'am.
indications. Okay. All right. Please tell me what are the ethical considerations that you'll keep in your mind while deciding for a patient to undergo dialysis?
As patient is, ma'am, dementia, as patient is having dementia,
Yes.
patient is not having a mind of
Yes.
giving a consent for the dialysis. So I have to start the patient on dialysis on the urgent basis by getting signature of the two consultants, ma'am. And
Very
I
good.
have to involve the registered nurse in the nursing of the patient, ma'am.
Which consent form will be used in this case for this
Uh,
patient?
Consent
Form.
two, ma'am. Consent form two, I think.
Don't say I think in exam. Okay, please. All right. Right. Okay. Can you please tell me what might be the complication if you don't manage high creatine level, or what is the complications of acute kidney injury?
Patient can lead to uremic encephalopathy and patient can die, ma'am.
All right. Okay.
And due to hyperkalemia, patient has a muscle cramps, muscle weakness, flaccid paralysis, paralytic ileus. Patient can have a diarrhea. Patient can have a hypotension, dysarrhythmia, and sudden death, ma'am.
How it can affect the cardiac muscles? Hypertension levels.
Ma'am, because potassium cause hyperpolarization, it arrests the heart in diastole, ma'am.
Okay.
It called cardioplegic effect on the heart, ma'am.
Okay. Can you please tell me why? Okay. Can you please tell me what's the function of aldosterone?
Ma'am, aldosterone helps in potassium absorption, sodium absorption, potassium secretion in the distal and collecting tubules, ma'am.
Okay, patient has how much urinary output? That
only 0.5 ml per hour per kg.
That is the normal one, right?
Yes, ma'am.
All right. Okay. How frequently would you monitor patients' vitals?
Ma'am, every hourly, ma'am.
Hourly or half hourly?
Half hourly, ma'am. Half hourly, ma'am.
Okay. If patient has obstructive renal failure, then what type of renal failure is that?
Ma'am, it is a post-renal failure, ma'am.
Yeah. Good. Okay. Can you please tell me, yes, how potassium levels or how potassium ions contributes to hemostasis?
Potassium ions, ma'am, help. It is influenced by the, ma'am, GI tract diet of the patient. It is controlled by endocrine system of the body. Like,
Yes.
for example, aldosterone controls it by absorbing the sodium through distal and connecting tubules and excreting the potassium. Insulin enhance the uptake of the potassium by the cells, and it can be influenced by our renal system. Acid base balance. It is
Yeah.
exchange with sodium potassium pump.
Yes. And how it affects at tubular level? How it acts at tubular
Ma'am,
level?
increased flow enhance the potassium secretions, ma'am.
Yes, very good. That's another way of diuretics. Good.
Yes, ma'am.
Thank you. So that's enough, right? And started the timer, and here is your question. Right. So if you have read and understood, considering that history techniques patient, kindly begin.
Okay, good afternoon. I am Dr. Muhammad, the treating doctor of today. May I confirm name and age, please?
I'm Jay, 26th of October, 1992.
Nice to meet you, Mr. Jain. Today I've been asked to take a history from you. So how can I help you today?
Actually, I have an appointment for 6 minutes. I need to take drugs. So could you please complete this taking history in a short period?
Okay, I will do my best to do that. So what seems to be the problem?
I have abdomen pain, and there is mass in my left thigh.
Okay, can you describe for me when this mess started?
It's about for 3 months, and it's gradually increase.
Okay.
Yeah.
And is there anything that increase or decrease it?
No. Actually, I didn't know about that.
Okay. And about your tummy pain, can you describe for me the exact site of this pain?
So it is it's mainly in the central abdominal, center of my tummy,
Okay.
and is severe in nature sometimes, but it's fine.
Mm-hmm. And is it radiated to any other site of your body?
No.
Okay, and this pain is related to specific times during the day or any other time?
No, it's not related to the time, anytime.
Is there anything that increase or decrease this pain?
Actually, no.
Okay, and if you can describe the severity of this pain from 1 to 10, being the 10 is the most severe. How much?
Previously it is 6, but now it's 3.
Okay, Mr. Jain, I'm sorry to ask you. I know that you are you have a drug after 6 minutes. For how long have you been taking this drug, and in which site? It is the same site of the mass?
I took for a long time, 3 years, and I took it in different parts here.
Different parts, okay. Do you feel any coldness in your upper limb or lower limb?
In lower limb, sometime, yeah, but in the upper limb, no.
Do you notice any weakness in your lower limb?
I feel numbness sometime.
Numbness, okay. Do you notice any skin changes in your lower limb?
No.
Like, do you notice any ulcer? Breach?
No.
Okay. Do you have any swelling or masses in any other sites?
No, I don't have.
Okay. Do you notice any discharge from this mass?
No.
Yellowish or blood discharge?
No.
Okay. Do you notice that this mass is reducible or not?
Actually, I didn't know what do you mean by reducible.
Okay. So you felt this mass before? Do you felt it's like soft or hard?
Yes,
Soft
it is
or
soft,
hard?
and it's soft, and sometimes it is decreased when I lie down.
Okay. So do you have any swelling in your lower limb?
No, I don't have that.
Okay. About your medications, do you have any medications? Have you taken any medications nowadays or before?
No, just sometimes I take paracetamol and I take my drugs.
Okay. And do you have any drug allergy?
No,
Okay. And have you done any surgery before?
no, I don't have.
Regarding your family, is there anyone of your family has the same problem before?
Yeah, my mother, she's take heroin also.
Okay. So what about your job? What are you working?
I'm not working. I'm not working.
And what are your previous job?
Previously, I'm working in a restaurant, but I left that from 1 or 2 months.
Oh, I'm so sorry for that. So with whom you are living, rather than with whom you are living?
I live with my girlfriend.
Okay. And do you smoke?
No, actually no.
Do you drink alcohol?
Sometime.
Okay. So do you have any problem with upstairs?
I don't have any things upstairs. So what do you mean by
Do you have problem with when I going up in the stairs?
Yes, sometimes it is causing pain in my leg. Yeah.
Okay. So Mr. Jain, do you have any chest pain or cough or shortness of breathing?
No, I don't have.
Do you have any weight loss or loss of appetite?
No, actually no.
Okay. Do you have any disturbance in your bowel habits?
No.
Do you have any problem with urinary passage?
Can you please present
No.
your case now?
Okay, to complete history taken, I will ask the patient about his main idea and what he's more concerning about and the expectation
good.
from us. Today I take a history from Mr. Jain, 66 years old, who has a swelling in his left side, and also tummy pain. As this is the swelling. This started 3 months ago, and gradually the tummy pain is central and severe. He has a history of drug injection. There is no any symptoms of abscess or lymphadenopathy
Yes, good.
or
Okay.
lymphadenopathy or
So
any
what are your
hernia.
provisional
So my
diagnosis?
differential diagnosis is pseudoaneurysm, arterial pseudoaneurysm,
Yes.
femoral pseudoaneurysm. I should also consider other causes such as abscess,
Yes.
such as an abscess, hernia.
Very good. Okay. What investigations would you ask for to confirm your diagnosis?
I will start by doing ultrasound and duplex and then duplex and arteriography and angiography.
angiography.
I will do and complete neurovascular and neurovascular examination of the lower limb. Then I will do an MRI for further diagnosis.
All right. What treatment or management can you suggest for this patient?
Yes, the treatment is however intervention by intervention radiology and the coiling the aneurysm, or by an opening technique and ligation of the aneurysm and then later reanastomosis. There may also injection of thrombin through interventional. And then I
can you please tell me Last question, how would you differentiate between a true aneurysm and false aneurysm?
Yes, true aneurysm include all the layer of the arterial wall, while
Very good.
the false aneurysm also only subintimal. Um,
Did just the outer two ones. Okay, good. Very good.
okay.
Yes. Right. Now I'm satisfied. And here is the question. It will know. Sorry. Yes. Yes. So if you have read and understood, considering the history taking station, kindly begin.
Yes. Hello, I'm Mr. Lazir, one surgical doctor there. Please, can I confirm your name and age, please?
Yes, I am Jane, 36 years old.
Hi, Jane. How can I help you today, please?
Yes, doctor, I can't take my breath, and this my I'm coming here for having an operation on my tummy.
Yeah. So I'm really sorry for that. But if you don't mind, can I ask you some question regarding your issue? Besides
Okay.
taking some notes and no concern, it's gonna be confidential. Are you okay with this?
Okay.
So can you tell me that when did it start firstly, please, Jane? The shortness of breath.
Actually, after I have known that I am going for operation for in my tummy,
Yeah.
this was around 1 week or 2 weeks ago.
Otherwise, before that, you were well.
Yes.
Okay. Did it start suddenly?
It was gradually.
Gradually. So since have you experienced it's constant or increase or decrease?
It's now in this day before, when I come to the hospital, it's almost it's increasing.
Yeah. So increasing on coming to the hospital.
Yes.
So do you use any regular inhaler?
No.
So since you have you experienced, do you get breathless on become anxious? Have you noticed that?
Actually, I have noticed that I am the one who I can't get anxious easily.
Yeah. So did it affect your daily activity or your daily life?
No.
Not affect your daily life. So have you been counseled before for this this issue or shortness of breath?
No.
Yeah. So do you have any chest pain, Jane?
No.
Okay. So have you experienced any fever?
No.
So uh, any cough?
No.
Okay. Have you been operated recently and be immobilized for a long time?
No. I am going to operation today.
Okay. So have you been counseling for any chest issue or cardiac issue or heart issue?
No.
Did you woke up gasping for your breath?
No.
Do you get breathless on lying flat?
No.
So have you been abroad recently?
No,
So did it hurt your chest, hurt you and press on it?
no, I didn't think so.
So this shortness of breath, have you noted that it is related to special position or movement or so on?
No, I didn't notice that.
So have you noticed that your heart racing increasing recently?
Yes, maybe.
Yeah, only on impending your operation or before that?
As I told you, when the day I know that I'm going to an operation, it is increasing gradually.
Yeah. So have you noted any change in your weight?
No,
So any change in your appetite?
no,
Any heartburn?
no,
So have you noted that you are sweating during this shortness of breath?
no,
So any sweating at the night?
no.
So now I will ask you, what do you do for living, Jane?
Yes, I'm working as a teacher
Teacher. Yeah, with whom at home you are living?
with my with my husband and parents.
Yeah. Do you have any social stress even at the home or at the occupation?
Sometimes.
Okay. So do you smoke?
Yes,
How many packs per day?
around less than one bucket.
Yes. Do you drink
Yes, socially.
socially? Yeah. So what do you think is the cause of this issue?
I don't have an idea, but I fear from hospitals and operations.
Yeah.
I found being in the hospital is very frustrated.
No fear. You don't must you must not feel fear from hospital. We are beside you. So you are concerned about anything else rather than hospital?
No,
Okay.
my operation.
What do you expect? What will you do?
I expect from you to relieve my pain and get out of the hospital as quickly as possible.
So do you have any medical condition for which you are receiving any treatment?
No,
Any surgery before?
no.
Okay. So I will ask you some question to review other system. Do you have any headache?
Bell has gone. Can you present your case now, please?
Yes, I present. Yes, thank you for your time, Jane. I will pass my notes to my consultant to figure out your issue and may arrange some investigation. Okay, thank you for your time. Today, I took history from Jane, 36-year-old, who presented for impending elective laparoscopic cholecystectomy. She was complaining of shortness of breath 1 week ago, sudden onset progressive cold just on attending to the hospital was increasing on an anxiety with no regular inhaler. She didn't counsel B before with no fever, no pain, no cough, and no symptoms suggestive of chest or cardiac disease, with no weight loss or appetite change. She is
So
she
according to your
yes,
evaluation or according to mini mental state examination, what is the score?
yes. So according that, this is an anxiety relating to a shortness of breath due to an anxiety related to impending operation, which is laparoscopic cholecystectomy. But I will consider the other causes of shortness of breath must be excluded in form of pneumonia, atelectasis, pleurisy, pulmonary embolism, uh, um, or any trauma.
Okay.
Yeah.
How do you suggest to confirm your diagnosis?
Yes, I will contact firstly the her GP to make sure that about any notes or investigation done before. I make sure that the patient will be done will do a basal APG and the ECG echocardiogram, and room air EBG. I will also consider the patient to make a network of support from the family relative and the network from her family that we will support her and reassure her before and after surgery. I will also discuss the patient that no fear and no worries from the surgery, and we will care her. This as regard the patient.
Patient is scheduled for elective laparoscopic cholecystectomy. Do you think patient is fit to go ahead for the surgery?
Firstly, I will discuss with my consultant and says, yeah, responsible for the care that, but if the patient with no documented notes of cardiac or chest condition that may hinder or prevent the surgery, so we will go ahead with the surgery.
Okay. Do you think patient appears to be demented? Do you think patient can or is fit to give consent for the surgery?
Yes,
Does
as
patient
regards the
have the
patient on
capacity?
evaluation, as regards the patient, if the patient can she retain information and repeat it, so
Did
she
you
can
try?
give.
Yes. Did you make sure patient can retain the information?
Yeah, as I asked her about some information, she respond, but it will be discussed also before the operation in another session to make sure that she retains the information. And I will discuss also from the patient notes from the GB for any obstacle about this. If the patient can retain information, give informed decision, she can give an informed consent.
Okay. Thank you so much.
Yeah, thank you.
Dr. Hamdi, would you like to give feedback first?
It's a little confused. The
Yeah.
patient is, I think for the first, it is an anxiety due to shortness, shortness of breathing due to an anxiety, but also the patient in dementia.
It was dementia. He himself asked for
Assume
it.
I
He did not take the dementia history.
I
Like
don't.
what I think Dr. Muhammad's history was focused on shortness of breath more than to ruling out if patient is dementic or not. Because there are certain questions, part of mini mental test, which he could have asked. He would have told you an address, and at the end of the history taking, he would have asked you to tell me 24 West Street, and then which year is it, and what's the name of the place where that patient is supposed to be in the pre-op clinic or in the hospital or wherever, and then recognize what doctor or what nurses does, and if the patient knows its date of birth, and patient is not supposed to be recalling the date of birth and when World War II was ended and who's the current Prime Minister of UK, and counting backward from 20 to 1.
Excuse me,
etc.
ma'am. Can I ask something,
Yes, please.
please?
Yes, please.
I
Yes,
think
as regard this station, the patient present that he has a shortness of breath as regard his elective laparoscopic cholecystectomy. So
Yes.
how I will take or evaluate the dementia? I asked the patient about the main complaint. How can I help you today? He told me
Yes.
that.
okay. I can answer you in the exam. It will be more pointed. The actor will be directed for that. So if it is a station of dementia,
Yes.
she will tell you, I don't
I don't know who I am. Yes.
I don't
or
know
why
who I am. I
came.
don't know everything. But if it is a
Confusion.
station of an anxiety or shortness of breathing, but it will represent a dementia as symptoms or otherwise, like, but it will be direct in the exam. If it is a dementia,
Yes,
the
it
actor
will
will
be
be
clear.
will direct you to the station.
Yes, I know.
So
I know,
it is
but
confused.
yes, a little bit, Dr. Hamdi, please. As regard the patient with delirium or dementia, I know that the patient will be, it's not obligatory or absolutely indicated. Maybe during hospitalization and maybe old age, but this station was mentioned by ma'am. The main complaint is shortness of breath, and according to the scenario you mentioned, the shortness of breath is only related on attendance to the hospital and the impending elective laparoscopic cholecystectomy.
This is
So-
what patient says in the traditional notes as well.
I
That's
didn't
why
hear, ma'am.
Dr. Hamdi. That's why Dr. Hamdi said this, because this is what the answer is written in the traditional notes.
Can I say something?
Yes, please.
Thank you very much. There are two stations in this situation. One, it's pre-op initius patient and a pre-op dementia patient. If you started to ask the patient about his case, if he told you, he should start to tell you he didn't remember. What is your name? I didn't know. I'm Sarah. Okay. Then another question. What is the date of birth? When you told that, he should say that. I don't remember that. It's maybe, I don't remember. So from that, you should go according to dementia skeleton. If she's answer your question, as Dr. Muhammad say, so he confused you and you confused. You ignored dementia in the question. And another Dr. Muhammad, he answer the question without any sign of dementia.
Yes.
So you did well, but the wrong should be guiding. The actor guide you either to go to the anxious patient or go to the dementia patient. If, for example, if you will need my name, okay, I'm Sarah. What is date of birth? Oh, I didn't know. Where I am. So we start in the skeleton like that. Don't worry.
It will be a lot more easier and straightforward in the exam. Or we can do it again. I'll rewrite in more clear words. Yes, because that's how it was written. But then I'll rewrite it. I'll write it more clearly.
If you want to do it now, we can do it as a just history. If there is a time, I will ask the patient, and anyone can ask if the time permits.
Yes,
As
Dr.
you like.
George.
Will I do
Yes,
that?
Good evening, ma'am. Good evening, everyone.
Good evening.
Yes, I remember yesterday when you said when we were reading the question outside the cubicle,
Yes.
we should focus on the question. When we are asking, when we get in and start asking the questions to the actors, we should bear in mind what we read outside.
Yes.
Like particular case, I know there were two scenarios. The patient had shortness of breath, which is more or less pointing towards anxiety and pre-op anxiety. And also it was clearly stated that the patient appears demented. I think that was clearly stated in the question. So I want to know, bearing in mind from what you said yesterday, knowing that this patient is already demented, can we go ahead and just do the mini mental state examination first, at least to even be sure that the patient is fit enough to answer other questions?
Yes. In the
stage.
exams, that's what they expect you to do. You do the minimal or you do the complete AMTS score, and that's what they ask you or expect you to do.
Yes, okay.
Even
Well,
if it's-
what I'm trying to say is for this particular question, can the dementia take precedence over the shortness of breath while when you start asking the question?
I'm sorry, I can't understand your question. When you should
Okay.
start asking,
So,
basically, if you look at the traditional notes, it says a pre-op confusion, but they have mentioned it or they have named it as Dr. Sridhar Murali is coming. He'll tell you. This is good that he's coming. He has recently given and passed in his first attempt. So we'll ask him.
Okay. Thank you.
Good evening, Dr.
Thank you, ma'am.
Sridhar.
Hi, ma'am. Good evening.
Yes, thanks for joining. You know, actually, we are having a confusion or discussion that dementia history taking exam, which came recently when you gave the exam. How was it? How was the question put forward?
Ma'am, it was not in my station. It was not, dementia was not a station in my paper, unfortunately. Mine was a
Okay.
new station. You remember the gentleman with the severe past medical history and came in for pre-op checkup.
Okay, but during that time, or you prepared, so maybe you can tell, because there are two. There is one station I know, pre-op confusion station for history taking, but in the traditional notes, but they sometimes label it as dementia because the patient is supposed to be in delirium and dementia. But then what they want to confirm is how should they start, or should they right away ask the questions according to mini mental examination, or how?
Ma'am, it's a so first of all, I mean, so there was two very similar stations. I don't know
Yeah.
if this is helpful or not, but for me, when I had my exam, there was clinical examination of the foot for a diabetic patient and the clinical examination of a back of the spine. These are two very similar questions, and it was very difficult to focus at that time during the exam. What I would suggest, or what I was thinking, or what gave me a little bit of clearance, ignored on the second station as well, is I forgot to read the fact that in the second case scenario where they were expecting me to actually do a clinical examination of spine alone, because the clinical findings were similar in both patients. The only thing was diabetic on the first station, and on the second station they had mentioned that the ABPA was normal, so which they meant that the leg examination was normal and you have to go for the spine. Same way in this similar, I mean, this station is a very big confusion for all of us when we prepare for this exam as well. I would think the Royal College would be definitely more, specific about the one, precise about the one that they want us to confirm. And also, if because of the anxiety or something, if some candidates are going to go the other way around and examine the first score, I mean, not directly the mini mental scoring. I don't think that's a bigger one. It takes a longer
time, but there is abbreviated or the mini mental test
that is what is expected. That was what I learned for the exam as well. I never, I mean, I was not able to recollect the entire for the details. Now, when all of a sudden I actually don't remember, but the mini mental scoring is what I actually studied for the exam as well.
Yeah, this is what everyone told me, like the feedback that I got, it was that. So I'm confusing. Maybe it was group who appeared before yours, because it recently came, and I can recall the person's name who had this in their exam. But anyway, right.
No, this is definitely not in my exam.
Yeah. So like I have members who are going for exams. So if you can stay. Otherwise, if you want to do it tomorrow, Dr. Hamdi, then we can do
Yes,
it
I can
tomorrow.
do it now. I can do it now if available.
Yeah, because now Dr. Sridhar has come, so he has recently given and passed in his first attempt. That's why, like, you people are going for exam. So if any of you want to ask any direct question, so it's kind of blessing that he has come, and he'll give you his first-hand experience.
Yeah, I have no specific question.
Yeah, maybe Dr. Kuldeep or Dr.
Hi.
Mohammed. Yes.
Hello.
Hi.
Hello, Dr. Sridhar. I just want to ask, first of all, congratulations for passing. I just want to ask you one question. Is there any station regarding health promotion station or something?
No, there's no station like that. Unless they've introduced it this year, I would have covered, I'm pretty sure. But it's basically, I mean, we've gone through the common set of questions, and we usually keep abreast with the normal questions that they ask. And the one thing that I would advise, or what I can give you as a feedback, is exactly the questions that are asked on the exam are exactly there on the traditional notes, and they will exactly ask it in the order of the questions that are there. So if you just stick true to the traditional notes, and whatever new stations are being added on, obviously we can't predict what the Royal College is. When news to a station that is being added, we have to recollect that and remember all the questions and put that back into the traditional notes. I think I was seeing I think Abhishek added a new notes with all the news stations as well.
Yes.
So yeah, I mean, I think if we can just keep as up to date with the new stations that come on, then obviously I think that's the best option that is there for preparing for the exam.
Yeah. What else would you want to give them advice? How should they prepare?
I mean, with preparation, it's obviously with always with somebody, it's always better. Or I mean, try and presentations. I don't know if there's an exam, is it, or international stations. I mean, international exams are slowly opening up, I think, isn't it, ma'am?
Yeah, that's right.
I mean, we obviously if we just
Dr.
practice.
Kuldeep will be giving in India, in
Oh,
yeah.
New Delhi, I think. Yes.
Yes.
Excuse, ma'am, can
Yes.
I add something, please, as
Yes,
regards
please.
this
Yes,
station?
sure.
Yes.
Sure.
Usually, this is the station of confusion, dementia, or delirium.
Yeah.
Usually came for many friends with the same pattern and form of.
Mhm.
You are a surgical registrar in the preoperative clinic. You have a patient attended for preoperative evaluation for hip surgery.
Yeah.
You are
Yeah.
asked to ask him some question to test his memory.
Okay.
Then the scenario after that, usually you will start with the abbreviated mental test scoring, which is 10 points to
Yes.
evaluate.
Yes.
And if the patient is less than 6/10, he is
Yes.
suggestive of delirium or confusion or dementia, but
Correct.
it is only initial evaluation of the patient. So to
Right.
confirm about there is a delirium or not, and the grade of delirium or the severity, according
Yeah.
to a normal patient, mild or moderate or severe, you must go through, even you ended it end or not, finish or not, you must start to or initiate to ask the patient about mini mental state examination.
Yeah.
Okay, which is 30 question, as you know, as regards the
Too
plate,
long,
as
yes.
regards the time, as regards the three undifferent unrelated objects,
Yes.
about
Yeah.
two familiar objects that is present
Yeah.
in the around your environment, around the count backward or a spelling backward of a certain word, and ask the patient also about making some duties in form of can you write a complete sentence, can you fold this paper like me into two half, can you please draw two outlines quadrangular object with 10 angles, especially with the two one must be intersected or transected. This is usually this is a scenario for this station. After that, and upon which the degree or the score, if you have according to MTS, I presented before. Regard the MMSE, if the patient has from 1 to 10, this is a severe degree of delirium or cognitive impairment. If the patient was 11 to 20, the patient will be moderate. If the patient from 21 to 26, so the patient is mild cognitive impairment. If the patient from 27 to 30, so the patient is normal person. According to this, we can categorize and upon which we can ask or can answer about the patient, he is eligible for the operation or not, he can retain information or not, he can give informed decision or not. So in which the patient eligible for to give informed decision or not. This is the scenario usually for this
Yes.
so this station. As this what I know,
Yes,
and at
please.
what I have been informed from our guys the previous exam.
True. In the traditional notes or in the exam, they have hip replacement operation, but like in my scenario, I've made it left colli. But then because it's a history taking station, I could not write it that you check patient's memory. I kind of
Yeah.
tried to give you impression that patient is dementic and scared and breathing heavily or whatever, like, so that you can get the idea yourself and you can continue asking those first 10 questions, the mini mental test. But that's all right. We'll practice again. I'll try to have it because I can't copy someone else's text, you know, so I have to have it my own. That's why it's a little different sometimes.
Yes, sure. I got the point from the station.
Yeah,
The lesson to avoid distraction from the first point from the original point. So
original
you
point,
must
yes.
complete. Yes, you must complete the station till the end and got the point.
Yeah, good.
Yeah,
And
this
then
is the lesson.
it's
This is good
what
for
you-
me.
Yeah,
Not
good.
yes. This is good. Yes, good for me.
Thanks. And then you can ask Dr. Shiv that he gave the exam, and you can say like I asked him afterwards. He hasn't taken any private tutors or anything. He just did the Royal College one mock course, or maybe something. He'll tell you what he did, or he
No,
just.
I attended an online course because there was no course that was happening over. So I
Okay, that was also online.
that was an online course, but that's actually only for UK candidates. So
Yes.
it's a separate course, and they did it for us. And that was just the course, but otherwise I only did your classes in the evening.
Yeah, so with that, what feedback he gave me that 90% questions comes from what he learned, and the 10% always are the new questions. And this is your residual knowledge, which comes handy at that time.
Yeah.
So hopefully, I don't think I mislead anyone. I wouldn't be misleading you people, definitely. And
No, ma'am. I don't say that.
no,
But
but still, there is confusion, you know, that
yes,
I can maybe.
With regards to the station, this is always a
I was
confusing
confused.
station for everybody. But I'm sorry, I'm just saying I mean, you were first we already start with the mini mental scoring. Sorry, the abbreviated test. And then after that, if the examiner asks if you actually, if the patient is actually scoring less than 6 in this case, then you could always say that, we're now considering that this patient is scoring less than 6, I would expect this patient is having. For further examination, I would like to do mini mental scoring exam. Ideally, but unfortunately, lack of not able to do it with this specific.
In Ireland exam, they actually told the candidate to do the full mini mental
Full
test.
mini mental. Okay,
Yes.
that's. I mean,
And she scored the
worth it to
highest
have it.
mark. It was a girl. That's why I'm
Yeah.
saying. I thought she gave the exam with you, but she maybe did before.
I
She
see.
managed it within the time, and she gave the
That's
highest.
very impressive. So yeah,
Yeah.
that's very.
Yes, so ma'am, in the exam, I'm sorry for interruption, but
That's
during the station, I will be asked in the scenario from the start to do test memory or to do
to test memory.
MMSE.
Yes. To test
MMSE.
memory. No, not the complete
test
one.
memory.
The test.
So I will start.
MMSE.
Yes. So I will start with AMTS.
EMTS. Yes.
Then go to MMSE.
If
Is that
time
right?
permits you, you'll say if time permits you, then I'll do the complete memory test.
Yes.
There is
yes.
longer one. Sometimes they ask you to test if you know exactly what that means, but not always. Only I just came to know about one candidate who was asked to carry it out, the whole one, and she did it, and she got the highest marks. She did really well. Right. Should we move on? Last station for today, maybe?
Yes, ma'am.
Eight, and started the timer, and here is your question. Right. So if you've read and understood, considering the
Yes.
communication station, kindly begin.
Hello, I'm Dr. Muhammad, one of the surgical house officer. I'm working for Mr. Man in hospital. I'm calling to Mr. Man, the hepatobiliary consultant, to ask him for transfer a case to transfer patients who has done recently cholecystectomy. Could I check that I'm calling to Mr. Man?
Yes, Mr. Man, with you. Can you summarize your case, please?
Yes, I have a female patient, 44 years old, who has done cholecystectomy. She is now in the post-operative day 4. She has complaining of abdominal pain and nausea and tachycardia. Her blood labs show a high TLC count 18 and CRB 15 and high bilirubin. On doing ultrasound, there is free fluid in the abdomen, but no common bile duct dilatation. So based on her labs, I am fearing of a biliary leak. So I am asking to transfer her for your care.
So, as regarding your demonstration of the case, what do you think the possible source of biliary leakage?
Yes, maybe direct injury to the common bile duct, maybe leakage from or bleeding from the liver bed, maybe an accessory duct, maybe the release of the clamps from the cystic duct.
Yeah. So, why do you think there is a biliary leakage? What have you noted today on the patient?
Yes, as the patients, as there is the patient has high TLC and high bilirubin, and in the view of the patients is tachycardiac, and there is a worsening abdominal pain.
So, upon which, what did you do at the regarding management of this patient?
Yes, I give the patient I give the patient IV fluid, and I assess the patients according to the CRISP protocol by maintaining patent airway and proper breathing and active circulation. And regarding the pain, I liaise with the anesthesia and the pain consultant, and also I'll start giving antibiotic after calling my consultant. The patients need extra investigation, MRCB, and she may need an ERCB to delete any obstruction, so that I transfer her for your care.
Good.
So what do you think is the aim of the ARCP, or even if you need to put a stent, what is the aim?
The aim of ERCP is to delete any obstruction in the common bile duct and or any duodenal obstruction, and for putting stent and or balloon.
Yeah. So do you think that urgent to refer the patient now? Why you can postpone till tomorrow or 2 days later on?
Yes, it is urgent for the fear of developing peritonitis, biliary peritonitis, and as it's now the flow there is a free fluid in the abdomen, and for the fear of developing biliary peritonitis.
So does the patient have abdominal drain, Mr. Hamdi?
Abdominal what?
Drain.
Drain.
Yes, she has abdominal drain.
So have you checked that there is a pile coming from the drain or not yet?
Yes, I checked there is a pile from the drain.
So could you tell me what is the amount of this pile coming from in the collecting bag?
Okay, I will check it and call you again and inform you again.
Yes, thank you. So what do you need to arrange with anyone before transfer the patient to prevent any corruption or misarrangement?
Yes, I will arrange with the bed manager for repartition of the patient or discharge of some patients for so as to have a free bed.
For which hospital? Bed manager of which hospital?
Of the hospital I'm transferring to.
Yeah. So who will accompany the patient before
Yes,
transferring?
Yes, I will accompany the patients and also the anesthetist and the ITU for any complications or if the patients need intubation.
Why anesthetist or ITU registrar? You mentioned that the patient is well and fit, and just lab investigation revealed on leukocytosis and elevated CRP. Otherwise, the patient is not apparently toxic. You didn't mention that. So why you need the ITU or anesthetist registrar coming with you?
It's as a patient may develop biliary peritonitis, and as I don't know, we can't determine the scale of the patients. We hasn't as he hasn't done CT. So we will take our care by having an ITU, especially if the patient develop any signs of shock.
Okay, so you can transfer the patient. Once
Okay.
the patient come to A&E department of our hospital, you can contact me by yourself or ask the SHO in charge to contact me. Okay.
Okay. Thank you, Mister, for your comment.
Thank you.
We still have 1 minute. You can meanwhile ask him what is biliary peritonitis and how should that be managed. Did you ask him if you need to talk to anyone, bed manager or anything?
Yes, I asked
Uh,
you need to arrange with someone before transfer the patient.
Yeah.
He mentioned that I will manage the bed
and if
manager.
there is no bed available, then what would you do?
So that's why I asked him to manage with both hospital at the
Yeah.
bed if is
Okay.
not available in our hospital, the patient will be kept in the his hospital
Yeah.
until the bed is available to avoid waiting of the
Yes.
patient in the other hospital.
All right. In this scenario, Dr. Hamdi, does the patient has drain in it?
Has drain?
Yes, I'm asking you, does the patient have drain in it?
abdominal drain.
Yes, please.
I can't remember. It's not written in the notes.
Yes, if in the exam it's not written in the notes, then don't say yes. Say, I'll get back to you.
I will check for that and
Yeah, what you
Okay.
said afterwards. Because if something is not there and you said it is there, next question Dr. Mohammed asked you how much is in that drain. So if you haven't seen it, it's not there, then don't say it's there. Just say, okay, I'll confirm it and I'll
Okay.
let you know. Good, thanks.
Okay.